So it is my sincere honor and privilege to introduce Gregg Gonsalves, Dr. Gregg Gonsalves, for the Grand Rounds lecture for today. His research focuses on epidemiology of infectious diseases and substance abuse at Yale Public Health. He also has joint appointments at the law school. He is a public health correspondent for The Nation, and he's a MacArthur Award grantee as well. In addition to this, he has also always combined his scholarly work with action. He was a member of ACT UP. He was a co-founder of the Treatment Action Group, and he was activist for his career. So I can think of no one better to in these uncertain times to point the way for public health. And so we're really delighted that you're here with us today.
Gigi. Hi, everybody. I'm glad to be here. This is not going to be your usual scientific talk. I could do those too, but not today. I'm going to take you back into history and then take you into the present, because at least for me, my past has a lot to do about how I'm responding in the current moment. Oops. This?
Yeah. Where did that come from?
You moved the mouse to the got it.
Oh, it's on the screen. Yeah.
Oh, that's good enough. So back in 1988, Vito Russo was a film historian who was a part of ACT UP, and I need to take you through the AIDS epidemic because that's where I grew up. I was in my 20s, the age of many of the graduate students in this room. I want to take you through it, for if you didn't live through it, you really don't know what it was like. And living with AIDS, Vito said, it's like living through a war in which it's happening for only those people who happen to be in the trenches. Every time a shell explodes, you look around and you discover that you'd lost more of your friends, but nobody else notices, and you can read the rest. I'm going to show you a little video to bring you deeper into the feelings of those times, and then we'll move quickly into the present moment.
My friends, David Evans, Nicholas Kaiser, George Marshall, and my beloved brother, Dennis J.
Robert R. Hackett, Philip Gregory Ellison, Terry Ronan,
Michael Bennett,
Donald Red,
Ron Field, Tina Chow, Perry Ellis, Freddie Mercury, Peter Allen, to the thousands of other people who were made to suffer in silence.
Join ACT UP for a political funeral. Meet at the steps of the Capitol at 1 p.m. Give a wake-up call to George Bush and Bill Clinton and Perot.
I think the quilt itself does good stuff and is moving. Still, it's like making something beautiful out of the epidemic. And I felt like doing something like this is a way of showing there's nothing beautiful about it. You know, this is what I'm left with. I've got a box full of ashes and bone chips. You know, there's no beauty in that. And I felt like a statement like this is like saying this is what George Bush has done. You know, this is what him and Ronald Reagan before him have done. These are our loved ones, and this is what they've been reduced to, and we're bringing them to the person who's responsible for their death.
So we're in pretty bad straits right now, but just to give you a sense that we've seen the dark times before. So I want to give you a little bit of perspective on what it was like back then to live through an epidemic in which the government really didn't care if you lived or died. These are some of the iconography of those times, posters that showed up in the East Village in New York, where I lived, in Boston and Baltimore and Washington, D.C. and L.A. There's no social media. There's no internet. This is the way we communicated with people out on the street who are not living in the trenches, as Vito said. We were pretty clear about why the AIDS epidemic unrolled the way it did in the United States back 35, 40 years ago. But it was more than protest and propaganda, right? Just a few miles from here in Rockville, Maryland, and Bethesda, Maryland, we revolutionized research and drug development. We opened up access to experimental drugs by speeding up drug approval through the FDA, through the expedited pathways known as accelerated approval, and the parallel track, which gave drugs to thousands, tens of thousands of people before they were approved and on the market with full FDA approval. We analyzed the gaps and the redundancies in AIDS research. I was no older than many of the people in this room when we passed the bill through Congress. We were organizing how AIDS research was done at the NIH. Didn't need a PhD, didn't need an MD, didn't need any advanced degree to figure out what the problems were in AIDS research and figure out how to solve them, and then push through reforms based on the strength of our arguments, but in our persistence and the work we did as part of ACT UP. We pressured clinical drug companies on clinical trial design and clinical research and clinical trial design. We had allies as well in the research community, but we did a lot with a little in a time of great peril. A lot with a little in a time of great peril. We revolutionized AIDS research and drug development by doing community-based research. The early studies of drugs to treat pneumocystis carinii pneumonia and other opportunistic infections were done by community docs and people living with AIDS, when the NIH was much more interested in the new retrovirus rather than old bacteria and protozoas that didn't have the sort of sex appeal of a new pathogen. And we did more than that. We invented safer sex. We invented needle exchange. We made laws to protect people from discrimination. We didn't do that in the halls of august institutions like the Johns Hopkins School of Public Health or any of the institutions that we thought should protect us. We did it out in the community. There's How to Have Sex in an Epidemic, which is a brochure my old doctor, Joe Sonnabend, did with a patient of his, because he understood that what was happening looked like diseases you got from immunosuppression, and said, why don't we put condoms on? And this pamphlet circulated to the East Village way before CDC got on the ball and understood what was happening to people in my community. But it didn't come easily, right? A lot of this is footage from Bethesda and Rockville, Maryland. Protests at the FDA headquarters, protests at the NIH headquarters. Anybody who's been to NIH can see Building 1 in the background. You couldn't do that today because of the giant fence around the place. But AIDS activism went global, right? A small group of people determined to change the course of history of biomedical research and AIDS treatment and AIDS care in the United States. That movement went global. And Johnny Steinberg, who actually teaches now at Yale, wrote a book called Three-Letter Plague, and he said, the idea of demanding that a drug be put on a shelf, that a doctor arrive at his appointed time is without precedent. The social movement to which AIDS medicine has given birth is utterly novel in this part of the world. The relationship between its members and state institutions previously unheard of. This is a country in which the president said HIV was not the cause of AIDS and AIDS drugs were poison, right? If you think RFK is bad, Thabo Mbeki and Montashabal Alamisabang presided over an AIDS epidemic in which 6 million people were infected, but the government wouldn't give them AIDS drugs. And the Treatment Action Campaign, pictures here, and what Johnny refers to, changed the course of history. South Africa, until recently, had the largest AIDS treatment program in the world. It wasn't the case in the year 2000. And a lot of people say, South Africa and the United States, we have civil rights movements, the anti-apartheid movement. It can't happen in other places that have less robust civil societies. These are friends in Russia with Stop AIDS and Front AIDS, who demonstrated in Red Square back in the early 2000s for the rights of people who use drugs to get access to clean needles and to get access to antiretroviral therapy. They put their lives on the line under great peril, with little resources, with great peril. And I'm telling you this is because we changed the face of public health, of global health, with very few resources. This is about hepatitis C treatment. Many of you know hepatitis C is now a curable disease with a 12-week course of directly acting antivirals, but they were $80,000 when they first came out. And working with people around the world, we were able to figure out how to get generic access to these drugs so that people who need access to hepatitis C treatment could get it in places outside of the US, even though Gilead refused to lower the cost. This is a report we did with our colleagues in India, but also with the Initiative for Medicine Access and Knowledge. Again, this is stuff that didn't take an army of people to do. We did it together with our community partners. And we're moving into the present now. Some of you do remember the Ebola non-outbreak in the US in 2014, 2015. In my neck of the woods in Connecticut, New Jersey, and New York, the governors were putting quarantines on people who had come back from West Africa. A nurse from MSF, two of our students, they were my fellow PhD students in the Yale School of Public Health PhD program in epidemiology, were put into quarantine, even though neither of them had the virus, right? I mean, who showed up at Bellevue Hospital in New York? It was the old ACT UP crew, right? This is 20 years later, 30 years later, and still the connection between disease and discrimination, disease and stigma, disease and bad public policy was fresh in our minds. Ebola is not a crime. So we continued to work, this whole social movement that AIDS gave birth to continued to work on behalf of not just people living with AIDS, but people with TB, with hepatitis C, people who might have been exposed to Ebola. This is a report we did as part of the program I run at Yale with the American Civil Liberties Union on the epidemiological and the legal problems with New York, New Jersey, and Connecticut's quarantines of healthcare workers and others back in 2014, 2015. In the last Trump administration, they tried to get rid of the ACA. Does everybody remember when John McCain put his thumb down? Well, there are about 20 of us in the Senate gallery. And when they were going to take the vote on the motion to proceed, we stood up and said, kill the bill, don't kill us. And they dragged AIDS activists away, but also clergy, rabbis, priests, imams, together off to the DC holding area for the police department. And that bill failed. We were told the ACA is going to fall. It's not worth fighting for. You're going to lose. But we still did what we thought was right. Now we're into the near past with COVID vaccines. How many of you have had a COVID vaccine at least once? That's great. There are billions around the world who never had a chance of getting access to these vaccines, even though many of the technologies were made with NIH funding and other kinds of federal support. And again, we push for access to COVID vaccines around the world. We did another protest outside of Ron Klain's house in suburban Maryland again, because too many people were being deprived of medical intervention that we all take for granted. There's antiretroviral therapy 25 years ago. Only 5 years ago was access to COVID vaccines. We also used our technical skills. This is a report that came out of Public Citizen called How to Make Enough Vaccine for the World in 1 Year. And again, this didn't come from a university. It came from community activists working with people with industrial knowledge to think about how you would have scaled up an mRNA vaccine back in 2022, 2024, so that people around the world could get access to it. I'm just giving you a sense that there's a sweep of work that was done that started 40 years ago when the AIDS epidemic first arrived in the US that continues till today. With Mpox here in the US, again, there were problems with testing. There were problems with access to the vaccine. And who showed up again? It was the same people who showed up 20, 30 years ago to fight for the rights of people living with AIDS, about getting vaccines out to the people who needed them across the US. So, fast forward. In November, I woke up after the election and I was petrified about what was going to happen. And I sent out this image on social media. I said, we're putting the band back together. The band that fought for AIDS drugs, for hepatitis C drugs, for justice for people who might have been exposed to the Ebola virus, to people who didn't get access to COVID vaccines. We need the same crew of people that had been working for the past 30, 40 years to come together in this crucial moment. And we started a new group called Defend Public Health, and which I'm going to talk a lot about over the next few minutes. Gigi's part of it, and others here at Hopkins are part of it. We started with a few friends who answered that call when I said we're putting the band back together, and now we have 7,000 people across the country who are willing to work with us. They tilt towards academic public health and clinical medicine, but we have lots of lawyers, we have lots of students, we have lots of former CDC employees, we have people who are still in federal service in DC and Atlanta, and we are ramping up our activities, which I'll talk a little bit about in the next few minutes. Let's talk more about what scientists can do as well. You know, I do have a day job, and as Gigi said, I work on HIV and substance use and other sequelae of substance use in the context of the health of people who use drugs. But I use the tools of mathematical modeling and quantitative analysis to do other things. Back a few years ago, there's a case in Texas that said where Braidwood Management, which was a company, said we don't want to give HIV PrEP as part of insurance to our employees because it can promote homosexuality and illicit sex, right? And became a serious issue. You know, can you, under the religious freedom provisions of current legislation, deny people the right to key intervention just because you have any religious objections to it? Embedded in that case was an attack on the U.S. Preventive Services Task Force, which had made these recommendations, and said that the task force itself was impaneled improperly, and all preventive services recommendations were null and void, right? And so my friends at the Yale School of Public Health and at Mass General Hospital, we said, well, okay, let's look what would happen if the Braidwood decision went poorly and that HIV PrEP was no longer available to people at risk for HIV infection. And you can read the paper, but the take-home point was that there were several thousand new infections each year you would expect if the Braidwood ruling cut off private insurance access to PrEP. It showed up in a Supreme Court amicus brief for the case, which was now Braidwood versus RFK Jr. Sadly, well, we won a sort of a victory in that the Supreme Court shut down the idea that PrEP could be taken away from people based on Braidwood Management's idea that this was promoting homosexuality and illicit sex. The court also said that the U.S. Preventive Services Task Force maybe is properly impaneled, but it's under the Secretary's discretion, which 2 years ago wouldn't have made much of a difference to us. 3 weeks later, RFK Jr. fired the entire U.S. Preventive Services Task Force. So we tried with trying to document what happened in the context of the Braidwood decision in its first iteration. What happened later was not what we expected or what we desired. Another piece of work with the same team of people at Mass General Hospital and Yale School of Public Health, Tennessee said they were not going to take HIV prevention dollars from the CDC because, again, they were going towards men who have sex with men, people who do sex work, et cetera. And they said, we want to move it towards pregnant women, victims of sex trafficking, and first responders. We said, that's fine. Let's look at what that would do in the context of deaths and infections. And again, there's additional deaths, there's life years lost, and additional transmissions here. Tennessee's decision to forgo CDC funding was not going to have any sort of public health rationale. But we wanted to be able to show it in the context of a rigorously designed simulation that put the case to study. And what's more importantly, Ethan Bohr, who was the med student who was the first author on this paper, he wrote a piece with a colleague in Tennessee about how these reallocations of prevention ought to do more harm than good. So the idea is you take what you can do through science and through quantitative analysis, but you don't leave it on the table or just put it into a scientific article. You need to put it into the world where it can shape policy decisions. That's part of the work that we do in my group. So we've seen the dark times, many of us. You all may have your own stories of those times. But the case I'd like to make to you is that, I was scared and depressed in November. I was angry and frustrated. And I realized that, we needed to organize together. And I can't tell you how important this is. And this is why we started Defend Public Health. And we're trying to build a movement together, right? We have started state teams in all these states where we have little sunshine logos coming out of them. And I would make the case that you should come join us, right? We're stronger together as a movement. We need to get through these years, and we need to get through these years better than we left them, right? And we're only going to do that through people power and the power of our determination, just as we started 40 years ago in the AIDS epidemic. Outside of the US, in South Africa and Russia, Ebola, hepatitis C, COVID, Mpox, all of the sort of community determination that we showed is not just a community of people living with HIV, but of clinicians and scientists as allies, was able to move mountains. And we need you to come join us in this work. So if you want to come join us, you can look at this QR code and you can get set up with a state team. I can send this out as well. But the idea is we started in November with a handful of people. Now we have 7,000 people. Robert Johnson Foundation came out of the woodwork, didn't ask for it. They said, we want to support you. And we're hiring 2 community organizers to build up these state networks. And so we can use your help because we're only as good as the people who are on the ground locally, who are committed to doing this work. I want to talk a little bit about the present tense. This is a piece that Ezra Klein wrote for the New York Times called Stop Acting Like This Is Normal. And Ezra Klein, sort of a middle of the road commentator if you read him, but he said what was happening in DC necessitated a government shutdown. And I know many people feel strongly one way or the other about it, but his case was that this administration is so out of control that the shutdown was a necessary corrective to stop business as usual, stop business in its tracks. We know it didn't turn out so well, that we didn't get Obamacare subsidies. We got very little for the longest shutdown in American history. But it was important that we were united together with our colleagues who work for the civil service, et cetera, in saying that the business usual cannot stand. As part of Defend Public Health, we've urged our colleagues in Congress to do the right thing, to stand up for public health in the budget. Right now, we're going to have a labor HHS bill that in which the NIH, the CDC, all the HHS agencies their funding it's the future of public health and environmental science hangs in the balance of what happens in the next few weeks in terms of that labor HHS bill. Senate bill will flat fund us, which is more than we could have expected 2 months ago. But the House could rip it to shreds. So we need people to work on direct pieces of advocacy around issues like this. Half the CDC has been fired. We need reinstatement of federal employees as well. And these are some of the campaigns we've worked on over the past few months and few weeks. Gigi and I were on a call last night, and we came up with 3 other things we need to be working on sort of with immediate import. One is, it's absolutely shocking, but the Department of Education has said that advanced public health degrees, MPHs, DRPHs, nursing degrees, physician's assistant degrees, occupational physical therapy degrees no longer qualify for the higher cap on student loans, right? So there's no way that people that graduate students in public health, nurses in training, PTs and OTs are going to be able to afford their education moving forward. This is a regulation that is on the books now. It's going through review and it'll get finally approved later this year. We have to stop this in its tracks. This will destroy public health as we know it. It will destroy public health schools. It will destroy primary care in the US. On our call last night that Gigi and I were on, an ER doc from Yale New Haven Hospital said, the barrier to getting people out of the ER, which is having a boarding crisis, is that the fact that many people need primary care, and need some way to get physical therapy once they're released. And all of this is going to exacerbate the healthcare crisis in the US, let alone the training crisis and the workforce crisis. In a couple of weeks, we're going to have another ACIP meeting. And the big thinking is that they're going to go after the birth dose of hepatitis B vaccine. All right. Another piece of work to work on together to see if we can get them to relent. Because we wiped out hepatitis B in children over the past 15, 20 years. We don't need to see it rise again over the next 2 decades. And finally, everybody knows about the COVID-19 vaccine recommendations. And we've watched how the American Academy of Pediatrics, the ACOG, and other professional societies have said children and pregnant women should have access to these vaccines and they should be recommended. Judith Feinberg, who was an infectious disease doc, actually spent time at Hopkins long ago, and Judy Stone, who's another infectious disease doc who's part of Defend Public Health, with an op-ed for STAT, and said healthcare workers under 65 must be vaccinated against COVID. There's nothing in the new recommendations from the CDC that suggests that healthcare workers should be a priority for COVID vaccines, or any frontline worker should be a priority for COVID vaccines. It's not. There's some of the new state collaboratives who actually put healthcare workers on that list, but Judy and Judith make the case that healthcare workers really need to be prioritized for COVID vaccines for their own health and the health of their patients, and the smooth and efficient working of hospitals and other clinical facilities. So this is right here and right now, which we literally 12 hours ago, a little more than 12 hours ago, we were on the phone talking about how to deal with these issues. So we will do state-based advocacy in which people can get involved in a Maryland chapter or DC chapter or Virginia chapter or wherever. But then there's sort of overarching issues that we need to work on together. These are the 3 sort of most potent ones right now in my mind. And it's been hard being in a conservative academic institution. I don't know about Hopkins, but mine is. My university president, when we went to go meet with her, she's a new president. Faculty from the School of Public Health, from the law school, from the medical school went to sit with her, and she said, I don't want a target on my back. I'm not going to speak up about the threats to our students, the threats to our research. I don't want a target on my back. He said, you already have one. And I wish I had said, your silence will not protect you, because they are coming for all of us. And the only way to stop them is if we all stand up together. So I'd lead you back to where we started about acting up, fighting back, and fighting AIDS, and realizing that you don't need 10 million, 12 million, 13 million, 14 million, 15 million, 17 million, 50 million people to change the world. Erica Chenoweth, who's a scientist at the John F. Kennedy School of Government at Harvard, said you need 3.5% of a population to resist to change the fate of an autocrat. Okay, so that is about 11 million in the US. But it's not as many as you think, right? So we feel paralyzed by the current moment and our fear and our anxiety and the risks that many of us face as individuals. Many of us, are undocumented, or people of color who risk deportation by ICE and have very personal risks right in front of them now. But for the rest of us who linger with more than a little privilege, we do have to figure out how to work together. The point is that you don't have to join Defend Public Health. That's one place to do it, but you have to join something. You have to do something. Because long after this is gone, and they write the history of this time, people want to know, where were we as individuals, as a collective of public health professionals and clinicians and scientists? Where were we? Did we trade another NIH grant for our graduate student futures? Did we trade another government contract for a DEI program, or the ability to speak out as a university president? We have those choices to make, and they're world historical, right? When the AIDS epidemic started, we didn't understand what was happening, what it was going to turn out to be, and we did what we thought was best for the people we loved the most. And so we're back in a place where we have an existential crisis to confront. Whose way of life gets to survive, right? Whose way of life gets to survive? And it puts us to the test in a way that I didn't really think I would see again in my generation. So I'll leave it there. And let's have a discussion. Questions, comments? Oh no. But this works. Hold on. I will share again. So if you, this definitely works. I clicked on it on the train, so I know it works. Yeah, and we'll try to hook you up with a state team. If there's no state team in Maryland, but I think there is, you can form one. Again, we met with Yale MPH students yesterday because we have a Connecticut chapter, and we said, look, all you need is a handful of people to take on an issue locally, and you're going to be off and running. So, other questions, comments, arguments?
What's your opinion on getting involved to push like policy at a state level versus non-government related issues or groups? Just because, like, in my experience, the entire reason I went back from to get degrees was to have an impact on policy. But as time goes on, it's continuously like the bar is moving, and the government is not interested in necessarily listening to us, as we're seeing like right now. So I guess like, what's your perspective on like pushing for a policy versus just using your community to like build resilience?
So that's a loaded question in many ways. So
yeah.
one is there's federal policy, which is difficult to influence right now, but it's not impossible, right? There's certain things that have happened, like the Dave Weldon nomination got pulled from CDC. There's certain things that have happened that were even too toxic for Donald Trump and his minions, right? So pushing on the federal level is important. But the reason we started state chapters is for two reasons. One is that a lot of good can happen at the local level. Public health is local and state, right? We can change regulations. We can figure, we're relatively rich state in Connecticut. We could figure out ways to bankroll services that are going to get cut or address things like work requirements and Medicaid, which are going to become onerous for many people once you have to do it every 6 months. But we could set up a program in Connecticut for navigators to help people. So we can do a lot of good on the local level. I want to be careful with the word resilience, because resilience always says like resilience presupposes that there was a state to go back to that was normal. And so I want us to have solidarity instead and build power and solidarity to our communities. And make things better for people. I don't want to go back to pre-COVID days. Things were not great for many. I live in New Haven. It's a poor city. The health disparities are epic. And going back to 2019 doesn't serve the needs of my community, right? So like, how do we figure out how to move beyond resilience to going back to some sort of primordial Eden and building something that's better? That's what we can do as public health professionals. We can use our science. We can use our skills. But we can just use our sort of arms and legs and bodies and minds to build power together at the local level, because that's where the rubber meets the road. We're in blue states, but we still have a lot of power, and I think courage in this regard is contagious. We have chapters in Kentucky and Texas where people are much more at risk for the work they do, but they know there are people around the country that have got their back. So I think continuing to push federally on some of these things, like the student loan stuff, we have to stop that in its tracks. But then think about what's at stake in Maryland or any of the states you may come from, and how you can get together to figure out how to make public health and healthcare and the sort of broader tent of what consists of the social determinants of health better in your state, and build power, build relationships. One of the interesting things is up in New York, Zoran Mandami the last weekend before the election said, we're going to get 200,000 doors knocked on Sunday. And they did it. And that should be the scale of our aspirations in public health, is to be able to organize our communities at that scale and sustain it over time. And so there's a lot of stuff to do together, which is a mix of science and politics, and just being a good member of our own communities.
So I really appreciate your talk, and I really also appreciate how community can have power and to influence policies that we're saying. But in my mind, we're kind of also leaving a lot of others out of the picture, which have a lot of influence. For example, industry and corporations that are also impacted, but can maybe at an easier level swing with whatever policy is. So what's your connection? What's your ideas for connection there? Because otherwise it's always only a people's thing, whereas we people interact not just with our policymakers, but also with the bigger corporations, which kind of operate faceless, right? And therefore also emotionless. So what is your stake and what can we do to, because they can have much more, they can add to the power, let's say that.
So some people are going to be impervious, like Elon Musk, right? I'm not going to waste my time trying to convince Tesla and the board to do the right thing. One of the interesting things that students did like at the beginning of this administration is that there are certain law firms that were folding to Trump, right? And a bunch of law students made a Google sheet and made a red, yellow, and green ranking of law firms. Red was like chicken shit, folded like a card table. Green were law firms who refused to sort of sign on to the Trump agenda. It went public, it went viral, it was in the Wall Street Journal. And it's interesting, we're working with a law firm right now as Defend Public Health to do an amicus brief in the American Academy of Pediatrics versus Kennedy case. That law firm is one of the ones in the green bars in that Excel spreadsheet, in that Google spreadsheet. So there's ways to think about influencing corporate actors. Some are going to be very sort of in their fortress of solitude, it's going to be hard to reach. But think about novel ways to reach corporations. Boycotts, I don't know how well they work, but there's certain ways to get under the skin of corporate leaders. I didn't show you any of the footage of the work we did in ACT UP, but when AZT, the first drug to treat HIV, came out in the late 80s, it was the most expensive drug on the market by far back then. My friend Peter Staley and others went to the Burrs Wellcome headquarters in North Carolina and riveted themselves in the office and said they weren't going to leave until they dropped the price of the drug. Of course, they left and were escorted out by police. But 2 weeks later, the price of AZT dropped. So you don't know where the pressure points are until you exercise them. And sometimes you lose and sometimes you win. Like we were not successful getting Pfizer and Moderna to relent on COVID vaccines. But we keep pushing and we figure out where the weaknesses are. But I do agree, like we have to go after the corporate sector too, the philanthropic sector too. Some foundations are also like too scared of their own shadows to step up in this one, but others are. Maya.
Hi, yes. Thank you so much for this. It was very interesting. I'm just kind of wondering what your thoughts are on what the administration's end goal is with all of this. It seems like they're doing, or not even it seems like they are doing so many things that are so detrimental and that seem like it would be disadvantageous even for them. And so I'm just kind of wondering what your thoughts are on what their end goal is and then maybe how we can mitigate knowing that or not knowing that, I suppose.
It's not a good answer. It's terrifying, actually. But if you go into the deep bowels of sort of the MAGA universe and people like Curtis Yarvin, who is the sort of House philosopher for J.D. Vance and Peter Thiel and others, this is not your ordinary administration. They're not trying to downsize government. They're not small government conservatives of the sea. Early on, people in the Atlantic and other places are writing, this is like straight up nihilism. What's happening to NIH, what's happening to CDC, what's happening to the public health loan programs, all of this is absolute destruction, right? So I think you have to be prepared that these aren't people who are working towards a constructive goal and just have differences of opinion of you about like how to reshape healthcare in America. They're hell-bent on destruction of the regulatory state, the administrative state. And I don't, if you read about Russ Vought, who's the head of OMB, his vision is pretty bleak. And it's tied to sort of a religious nationalism as well. I mean, this stuff is beyond belief, right? It's moved into a register that you do not reason with, you do not argue with, right? Because they don't really care what you have to say.
One thing I worry about with like modern movements or mass assemblies of people is that the public attention span and consciousness for specific issues has gotten so short. And then when you compare it to the AIDS epidemic, I'm just wondering what are modern tactics that we have, for example, addressing the attack on public health, which is a really broad issue that is going to be a sustained thing throughout this administration. For something like the AIDS epidemic, was there a struggle to keep it in the public consciousness, and how was that dealt with then, and how are we updating our strategies now with this new media landscape?
So you're asking the questions that everybody I know is asking right now. There's a book by Francis Scott Piven and a colleague a while ago called Poor People's Movements. And it's about the suffrage movement, the civil rights movement, the Black Power movement, et cetera, the labor movement. And it talks about how things go in waves. So certain social movements have their time and then they ebb. They often are based on what I consider concessionary victories. Like in HIV, we changed the NIH policy on X, or we got this drug price down, but we didn't change the fundamentals of healthcare in America. And so I think we have to think of a new sort of organizing framework for moving forward. This is why when we were talking about solidarity in communities, we need to build power in communities so that we are not mobile. So there's a labor organizer who died last year named Jane McAlevey, wrote a book called Organizing to Win. And she talks about mobilizing, where you have an issue, you get your groups of friends to fight, and you defeat that bill or you pass that bill. She talks about real power is in organizing, and it's building out a constituency that's beyond the usual suspects and the people who might agree with you initially. And that's what we've been focusing on in Defend Public Health, is figuring out how to build a grassroots movement that is not tied to one single issue. Because if we talk about public health is an incredibly broad field. It's housing, right? It's immigration. It is, straight up bread and butter epidemiology, but it's a whole host of social determinants of health that matter to people. And so we could build a long-lasting movement on a whole set of issues if we build the people power first to form that base. And it's hard. It's really hard to do. But we have to try.
Sorry, I didn't introduce. I'm Bennett Lier, professor here. And I had another question building on what you just said, but also a little bit earlier where you were saying you don't want to go back to 2019 and that. And this is, I think, exactly what is missing, because all these, even these examples that you're giving are really good, but they are reaction to what's going here. But at the political level, but even at this, where are we going with public health? What's the vision? What is that leadership? What is that goal? What's the alternative for what now? In the sense that beyond only responding to all the bombs that are falling down on us and things like that, is there a vision? Is there a map out? Is there a future where there's better? Is there a plan? Because that is where I think otherwise you can exhaust yourself just by responding all the time, right? Whereas you can get new energy and lasting energy, which actually can replace if you have an alternative. So what is that alternative?
So I don't know, but again, yesterday we were on the phone talking about these state level chapters, and the guy who's doing our organizing said, we really need to come up with a better alternative. And he said, we really need to get people at the state level to figure out what's important, and then get people at the state level to come together at a national level to figure out what's important. And I said, you're talking about like a constitutional convention model, right? Where the Pennsylvania delegation, the Maryland delegation, New York delegation comes up with a set of proposals about how to make a 22nd century public health. And then we have a discussion together. I don't think it's a wild idea. I think it's important to figure out how to do this from the grassroots up, to build community engagement, community commitment, and community interest in this. So we could leave it to the think tanks in DC, and they'll come up with Project 2029 for the Democrats or for the future vision of public health. I don't think that's sustainable. I don't think the technocratic solution coming out of Hopkins or Yale School of Public Health is going to be what it takes. But public health does matter to people. Public health does matter to people. And if we can tap into that energy at the grassroots level, I do think maybe John's idea of a sort of constitutional convention around public health is a wild one, but I do think it's the right kind of model of grassroots mobilization and thinking together. Because, top-down logic has not really served us well over the past couple of decades.
That's a question.
So, well, thank you so much for a great lecture. You all the time and develop your view. And I think that to Ben's point about like what budget faculty, like organizing is just talking to your community. At the end of the day, you don't have to always go to protests to just talk to your friends, and that's organizing. But I have a question for you on when you feel like the leaders in your general space, like what you said about your president at Yale, sort of either give you the runaround or don't have your back, where do you turn to? There was a group of us here who were going to write a piece about the public health implications of what's going on in Palestine, is going on with different infectious diseases, different crises, ecological crises. We're School of Public Health, and the former dean and was not receptive. It was very hard. Didn't do any math. We couldn't do the science that we wanted to do, and basically we're shut down. It was hard, and didn't really have another avenue to turn to. So, where do you recommend going to when your institution isn't back here?
So, these institutions have been around longer than we have. They've had many, many decades, sometimes centuries, to get stuck in their ways, right? They're not going to move quickly or courageously in the best of times, right? The first thing I tell my students is find your people. One of the nice things about Defend Public Health is that, I wake up with emails every day from people who are down for the fight, right? And some of them are retired virologists. Some of them are, high school students who are interested in careers in public health. So find your people. Also figure out, pick your battles, right? I could hammer on at the Yale president and keep pushing her to do the right thing, but I don't have any faith for the institution to do the right thing in the long term. So figure out where your resources can be used most effectively and don't bang your head against the wall. You can still do the work you want to do. It may not be at Hopkins, maybe after you graduate, maybe in some extracurricular on your own time sort of work. And I have a day job. I'm a researcher funded by NIH grants. But in my own time, I do the other work, and I do it with people who I know have my back and who support me.
And I think 20 is getting that kind of step. This is happening. And my expertise is more on the basic science. So other than policy, you had talked about operationalizing HIV drug manufacturing scale. Where do you see opportunities for basic science to jump in these areas?
So it's interesting. So we have a coordinating committee for different public health. And does anybody know what a northern blot is? So the guy who developed the northern blot, who's a retired virologist from the University of Pennsylvania, is on our coordinating committee. He knows a lot about basic science and virology, but he also is I need to throw myself into this work no matter what my actual day-to-day job skills are. So as a basic scientist, just get involved in the work. If there's something in your basic science toolkit that might be useful, figure it out. But you also, the basic scientists, have a whole set of analytical skills and intellectual skills that are useful no matter what, right? There may be a time where, like, how do we develop a industrial process for COVID vaccines? That maybe would be your particular chance where your professional and personalized matchup. But there are plenty of basic scientists in defend public health whose day job is, lots of pipetting and doing a lot of basic research. But in the off hours, they're organizing and doing the work that I described today.
Thank you so much.